Okay, there you go. Yeah. So the first few slides are going to be talking about the extent or the magnitude of the problem. This is a slightly old slide, as you can see, but in general, this would be our distribution of cancers based on incidence and in terms of how many of these contribute actually to survival and death. That has been calculated here. This is from 2021. You can see that in terms of estimated new cases, which is the incidence of cancer overall, all comers, if you're looking at this pyramid here, you have the GU system, genital system, digestive, GI cancers, breast, respiratory, skin. In terms of what contributes to death, how many of these, the GI, gastrointestinal, seem to be more fatal than respiratory, and then the other ascending order of that. If you're looking at distribution gender-wise, males and females, again, as you can see in this pie chart, in men, prostate cancer being more common, followed by lung and related cancers, and then come some of the others, colorectal, which is gastrointestinal, and then the rest of the pie is distributed among all these other types of tumors. So also in women, breast cancer being more common, and then lung just follows suit over there as well, GI or colorectal, and then the rest is again distributed and shared by different tumor types there. Getting into some more specifics about lung cancer per se, as it is commonly known, risk factors. For lung cancer, smoking is a well-known risk factor. It has been shown, a lot of times people ask, what about secondhand smoking, even though I have stopped smoking? You know, I would say depending on the extent and the duration of secondhand smoking, how close and if it's on a daily basis versus not, I still personally feel that does play a role. And that's why we have efforts now towards smoking cessation, towards screening patients who are at high risk by virtue of active smoking status or even recently quit smoking status. Screening methods such as CT scan of your lungs done once a year is something that we are actively taking on. Insurance companies are also providing coverage for that. This is something that has been taken up by various health institutions, and I think it has made a difference in our numbers. As I go on to talk about treatment and staging of lung cancer, we are starting to pick up more and more early stage cancers because of this initiative. Kind of similar to what we see with breast cancer in women, where we say mammograms pick up cancers early. So it's a similar analogy we're seeing for our lung population, where when patients have high risk because either they're active smokers or even if they have recently quit smoking, our guidelines have a certain cutoff within the past 15 years or so. So it's a wide range that we have. They're still eligible for getting the CT scan of the chest once a year. Primary care doctors are the ones that discuss this with patients, just so that we can pick up these cancers at an early stage, because when you detect cancer at an early stage, the higher chances of cure are higher there. Radon exposure is somewhat of a less known cause here. A lot of times we also see patients without active history of smoking or a very remote history of smoking. They quit smoking decades ago and still are faced with the diagnosis of cancer. And then the question comes up, so what else could it be? So there are studies done. We know that environmental exposure to radon gas, which is a heavy gas that usually settles on the bottom, typically in the basements is where we see, possibly plays a role also. So when I have a non-smoker or a very remote history of smoking patient that has lung cancer, I tell them perhaps get radon testing done in your basement and see. The levels are high. There are mitigators available now that you can install just to get the gas out in the atmosphere, and that way you're taking away that potential possible risk factors. Not going into details, but if anybody wants information, I'll be happy to share afterwards how you can install a detector and then how to go about with the mitigation process. So delving right into the actual types and other aspects of lung cancer, question I commonly get asked when I start talking to patients about their cancer is, what is my type? Because a lot has been said, written in the literature when you're on blogs or websites and talking to other patient sites. They talk about small cell, non-small cell, or adeno. These are different names that you come across. In this day and age where everything is available online, these are terms that you come across. So I just wanted to put out those names so that you have some familiarity that way. So broadly speaking, I always say lung cancer is mainly two types. These are the more common ones, small cell and non-small cell lung cancer. There are some other less common types that we have also. Neuroendocrine cancer is not as common, but we see that as well. Mesothelioma is another type of actually lung cancer, not quite the substance or the tissue of the lung, but the lining of the lung. So this is also a subset. This is more common where you see those advertisements where asbestos exposure linked to that. I should have probably put that in my other slide as one of the risk factors for a particular type of lung cancer being that. But yeah, in general, these are all the types that we come across. By far the most common is non-small cell lung cancer, NSLCS. That's how they abbreviate it when you read about it. Small cell is actually only about 15%. Non-small cell is a mixed bag. It has different subtypes in it. Adenocarcinoma, squamous cell carcinoma, large cell carcinoma. These are all other subtype of non-small cell cancers. A common one that can occur in non-smokers is usually adeno. If somebody has no smoking history, never smoker, and develops a lung cancer, it's almost always this subtype adenocarcinoma with the small cell cancer. I have so far only seen one patient, I think maybe two, with squamous cell. That's in a non-smoker. I've never seen a small cell cancer in a non-smoker. So that's exclusively seen in smoking population. Large cell cancer is another rarer type with non-small cell cancer. Neuroendocrine carcinoma. This is kind of a common term that we see. There are other parts of the body where you can get or you can see neuroendocrine cancers, gastrointestinal system in the intestines, appendix, colon, you find those tumors. You can have some in the liver, but lung is quite a common site for that. There are different subtypes, again, carcinoid tumors, atypical carcinoid, poorly differentiated neuroendocrine, which is a more aggressive type, which is kind of similar to small cell, we say. These are all different types. For the purpose of the discussion and talk today, I really have not gone into any of the details of mesothelioma, because it's not as common, two, I guess because it's not that common, so I just left it off. But again, if anybody's interested in more information on that, I'll be happy to share later on. So these two being more common, I just thought I'll give a little more details about this. And my next slide actually has a picture of what it looks like under the microscope. That may be a little more information, but I figured a picture is always worth 1,000 words. So once you see that, perhaps that'll stay in your mind to help identify or differentiate why these names have come about at all. Small cell, now why do we give them these names? Why small cell and what is non-small cell? Why don't we just call it large, you know? So small cell cancer, the main feature here is when you look at the cancer cells under the microscope, they appear small, small round blue cells, we call them. Non-small cell, on the other hand, they're usually made of glands. I'll show you in the next picture. It's like circular, different shapes and sizes. Small cell is actually the most aggressive type of lung cancer. And usually when I tell my patients this is the type of cancer you have, the first question they ask is, so is it bad? Which one is a better one to have? It's better to have small cell or non-small cell. So small cell is very aggressive. In that way, you can look at it as a bad one, but it is also a good one because it's very sensitive and responsive to treatment, which is chemotherapy and radiation. These treatments oftentimes melt the tumor away really well, unlike some other tumors. Non-small cell, again, not so aggressive. You know, the adenocarcinoma subtype I talked about, that's more common in non-smokers. That's actually quite a slow-growing type of lung cancer. Squamous cell cancer, which is another type of non-small cell, probably a little more fast growing, maybe a little more aggressive. But in general, if you look at the difference between the two, this by far is the quicker growing one. This is not as quick. Non-small cell, typically, if it's early stages, surgery offers the best chance of cure. Whereas for small cell, we usually don't talk about doing surgery. This is a cancer type where chemotherapy and radiation play a major role in shrinking and controlling it. But non-small cell, again, because it's somewhat slow growing, if you pick it up and it's early stage, you could offer surgery, and then that's how you could hopefully get rid of it. And one important thing to understand is because this type of cancer is so aggressive, by the time you diagnose it, the cancer is usually large enough where surgery is not even something we talk about. That's why we go on to chemotherapy and radiation there. Ashley, how do okay, I moved this here. Got it. So this is what I was talking about, what they look like under the microscope. If you look at this, those tiny little deep blue dots, round cells scattered all over. This is what it looks like. This other one, non-small cell, the adenocarcinoma, these form nice little glands that you see, these little circles that you see, the appearance. Again, this is not something I can identify either. It's our pathologists who give us this diagnosis when we do a biopsy and look under the microscope. This is all done behind the scenes. Squamous cell, again, you see all these cells scattered around. They have a typical classic appearance, and that's how they make the diagnosis there. I'm not sure if this is projecting well or not. Ashley, could you help with this? Is this showing in full screen, or is this just showing part of the screen?
Yeah, so if anybody has any issues with the view, I would recommend going up to there's a button at the top for change your view, and you can do content focused, and you'll see it in full screen. So from your end, Dr. Rackham, you're doing just fine, and everybody can adjust on their screen as they need to.
All right, yeah, because once this is minimized, you're not able to see the other text. Yeah, the text itself can be self-explanatory as you're looking at the slides. So with this slide, I just want to give a brief overview about what we call as staging of cancers. These are things people ask, okay, so what stage is my cancer? You know, the numbers stage 1, stage 2, stage 4, all these things are commonly talked about. So in general, cancer has 4 stages, 1, 2, 3, and 4. Stage 1 is when the tumor is just localized to the organ where it starts. So in this case, in this picture, it's just in the lung. So that is stage 1. Stages 2 and 3 for lung cancer mean that the cancer has spread outside the organ, outside the lung, and moved to the lymph glands. Now, lymph glands are basically, if you had a cold or a sore throat, you probably felt swollen glands in your neck. Those are lymph glands. We call them lymph nodes. We have lymph nodes, different parts of our body. It's in the neck, armpits, and groin. You can feel those. We also have them in our chest, and around the stomach, in the abdomen. You can't feel those, but you can see them on scans. And lymph nodes are important because that's how cancer travels from one part of the body to other areas. So anytime we find cancer in one area, we always want to know, did it spread? So what is the status of the lymph nodes that are close to that? So as you all may know, this is your right lung, this is the left lung, this is the breathing tube called the trachea. It splits to supply the right and left. So this is called a bronchus, right bronchus, left bronchus. Example of cancer here, the yellow dot. If it spreads to the lymph nodes here, then we call it a higher stage, stage 2. Now, the same tumor moves from the lymph nodes here, that is, these are lymph nodes in the lung, and goes to the lymph nodes in the middle of the chest, slightly away lymph nodes these are. Then that would make it stage 3. It's a little farther away. The next one is stage 4, which basically is the cancer cells have traveled outside the organ and gone to other areas. It could be the brain, it could be the bones, it could be the liver. In a sense, it's other parts of the body. So that's what stage 4 cancer means. That the cancer cells have traveled outside and they have gone out. Metastatic cancer, that's another terminology used for that, stage 4 or metastatic cancer. That's what that means. And this simple rule actually holds good for most other cancers. Breast cancer, colon cancer, prostate cancer, it's the same thing. If it's confined to that organ, it's stage 1. it moves to the lymph nodes in the nearby. In some cancers, that's stage 2, some it's stage 3, some it's both. For lung, it's both 2 and 3 is lymph nodes. It's the location of the lymph node that differentiates between whether it's stage 2 or stage 3. And if it moves away other organs, then it's stage 4. How do we treat when you have these different stages? You know, how do we treat, as you all may know, or some of you may know, cancer is generally treated by these different modalities. The basic mainstay of treatment, there are 3 main types. One is surgery, where you cut it out, you remove it. Second is radiation, which is powerful X-rays that you give to the tumor to kill the cancer cells and shrink the tumor. The third type, actually, I want to club it in this category. All these 3 are under one big category. The third type, the way we treat cancer is you give the medicine, or you put a medicine into the bloodstream. You put it in the blood in different ways, and the medicine just circulates throughout the body, and it goes and kills the cancer cells wherever they are in the body, be it in the lung where it's starting, or in the lymph nodes where it's spread to, or other body organs where it already spread to. So I don't have a common, simple English term to combine all these, but medically it's called systemic treatment. Systemic means system-wide. You know, I guess that would be the common, simple term to use, because surgery and radiation are pretty much focused to wherever you do it, whatever you use to treat. With surgery, you're cutting it out, you're removing that part, so it only helps take care of the cancer in that area. Same thing with radiation. You give those powerful X-rays to the tumor, and it's only going to help it there, but it does a very good job with the early stages. The system-wide treatment here is a medicine you put in the blood that will go throughout the body, and it can kill wherever they are in the body. So that is of 3 types. Chemotherapy, which is a very well-known modality. Something called immunotherapy. This is a newer one now. A lot has been said about it. You turn on the TV and you see multiple ads for this, heavily advertised in media. Immunotherapy, both of these are given into the blood through an IV. So I'll have some pictures to show that in a moment. And the third one, which is also fairly new, is called targeted therapy. That's usually in the form of pills or tablets or capsules that you swallow. Ultimately, the same goal. When you swallow it, it goes to the stomach, gets absorbed into the blood, and goes throughout the body. So mainly, broadly speaking, these are the different types of treatments we use to treat it. One slide quickly about surgery, what it would help and how it would. Basically, you're removing the tumor with surgery. That's what the goal is. And it is used in early stage situations. So I have to say, I don't think I'm able to see these clearly, but lobectomy is basically you're removing the whole lobe. Now, let me just go back real quick to this picture. So in general, this is the anatomy, how the lungs are structured. Right lung has 3 lobes, upper, middle, lower. Left lung usually has 1 big lobe. There's another called lingula here, and then a lower lobe. So different lobes of the lung that we have. So typically when they do surgery, ideally they remove the tumor, the cancerous area. Not just that, they also remove the whole lobe with it. That's the right way of doing it, because you want to remove all the lymph channels and everything that might go with it, that where the cancer cells might be spreading. And when they do that, the surgeons also remove the lymph nodes. Even if the initial tests that we do not show any cancer spread to the nodes, even though we believe that it is stage 1 and didn't move to the nodes, when they do surgery, they always remove the nodes, because we want to be 100% sure, remove all where the cancer cells could possibly spread to. So this lobectomy is ideally the type of surgery they would want to do. Now, sometimes if a person's lungs don't allow, then the surgeon may not remove the whole lobe, but only removes just the part of the tumor by itself. As you can see in this picture, it's called a wedge resection, shaped like a wedge. Again, assuming that the cancer is up here. The cancer is here, then they'll pluck it out just there. So wedge resection is another alternative type of surgery. And this is something that the lung surgeon would decide if a person's lungs are strong enough, healthy enough to tolerate it or not. A third type, which is becoming more and more popular now, and again, I'm not a surgeon, so I don't claim that I can give you all the data or information about this, but I have heard from my surgical colleagues that something called a segmentectomy is pretty good as a lobectomy in terms of what it can achieve and accomplish, where they don't quite remove the whole lobe, but just the segment that has the cancer. And of course, they'll remove lymph nodes and all that. Sometimes if the tumor is very large or sits between the lobes, they may have to remove the whole lung itself, and that's called a pneumonectomy. Again, the surgeons will make sure that person can live with the other lung. We have two lungs, I always say. Nature has it that way. Duplicates of some organs and only one for some other organs. So lungs, we have two. So if lungs are healthy, yes, we do see people living with a single lung also, if the other lung has to be removed for the purpose of treatment. So yeah, in general, broadly speaking, these are different types of lung surgeries. Radiation, which is the other type or second modality. Again, let me move to one slide further just to give some pictures here. So radiation is a treatment, again, where they give powerful x-rays through a sophisticated machine and equipment here. You see the patient laying on the table going into this. That's the machine that delivers radiation. These powerful x-rays go and hit the tumor. Patient actually doesn't really feel anything there. And this is what it looks like when they do their scans. The radiation oncologists do their scans and their own imaging. These powerful x-rays go, hit on the tumor there, killing the tumor and shrinking that there. Again, this is very, very basic for radiation. I'm no expert, I'm no radiation oncologist, but this is typically what they say, types of radiation treatments. Photon treatment, which is the general type of radiation treatment we talk about. And then there is proton, which is another type. I just at least wanted to introduce these terms because I get asked these questions quite a bit also, that because protons is something fairly new, relatively new, not all places in the country offer it. There are some specific locations which are actually increasing and becoming more common now. It's a type of radiation treatment. It's not under surgery or not under chemotherapy. It's a type of radiation treatment. Photon radiation is a more common one. The more common type is where they give radiation, actually x-rays to the tumor, the cancer that is, and the lymph nodes surrounding it. There's different types of treatments here. I just included one. This might be a little more information, so you don't have to pay attention. A second type of radiation treatment is only the cancer spot is targeted and the lymph nodes are not taken into account, or they don't treat the lymph nodes. One such treatment given to different organs of the body is called SBRT, which is like pinpoint focus radiation, stereotactic body radiation therapy. That's the full form for that. The second type, which people may be more familiar with because of the name, is gamma knife. That's used, that's also a pinpoint only to the tumor. That term is used typically, at least here at West region of Northwestern, Delnor and Central DuPage and Kishwaukee, where we send patients for that. When you treat the tumors in the brain, they use that. Cyber knife, again, is another such term that's been coined and out there. But these are, broadly speaking, the types of treatments there. Systemic treatment, which as I mentioned earlier, all those treatments that are given through the blood. This is something I can talk more about because I'm a medical oncologist and this is what I deal with all the time. So this is something I can go into some more details. Chemotherapy and immunotherapy, these are basically medicines given into the blood. Patient is seated in a recliner. The medicine itself is hung in a bag like this. Our specially trained nurses infuse or instill or give this medication this way. Targeted therapy, as I said, is in the form of a pill, capsules or tablets. So you swallow it by mouth. And once again, the same principle, it gets distributed through the blood and goes throughout the body. And these terms and this concepts that I'm just talking about is true for most cancers, not just lung. Again, a lot of times people ask, what is this immunotherapy? What exactly is it? And, what's all this buzz about immunotherapy in the media? Why is it different from the good old traditional standard chemotherapy? So I tried to put a couple of slides here with cartoons, just trying to explain what it is, kind of in a scientific way, but not quite as scientific. Try to simplify it. So when you give that medicine into the blood, as I showed in the previous slide, that goes through the IV into the blood, and it goes and sits on the cancer cells. So the green ones here are cancer cells. The deep blue or purple is your drug molecule. Sit on that directly. So it'll attack the cancer cells directly, wherever they are in the body throughout circulation. And then this chemo actually kills the cells directly and then prevents them from growing. So this bright green is now like moss green, dark green, because these cells are dying, they're getting smaller, they're shrinking. So chemo, the basic principle is it attacks and works on the cells directly. Immunotherapy. This is a very hot slide. Most of our conferences, we see this picture put up at least once in all our conferences. I'll try to simplify because there's a lot of scientific information here. So the yellow here is the cancer cell. This blue purple is your healthy cell. Normal healthy cell, this is the immune cell, we call it. It's a type of white blood cell. It's called T cell. It's a type of white blood cell, which is your own body's immune cell. This orange triangle you're seeing is actually the immunotherapy drug. So when you give the medicine again into the blood, this is what happens normally in the body. When you have cancer, the cancer cell and body's immune cells are kind of talking to each other with different receptors and molecules that way. What happens when you give that medicine immunotherapy into the blood is, see this orange triangle here goes and blocks or sits on one of these receptors here, which are on your own cells, the body's healthy cells. And as a result, because of some transmission of signals, which happens at a molecular level, ultimately the cancer cell dies. So you see it breaking off and then shriveling and then shrinking and going. So this medicine does not work directly on the cancer cell, unlike chemotherapy, but this immunotherapy medicine, it revs up your own immune system to help your own system attack cancer cells and kill the cancer cells. So that is the basic difference between the two. Immunotherapy is also gentler on the body than chemotherapy. As many of you may know, chemotherapy can cause a lot of side effects because when it attacks the cancer cells directly, it's not very smart, because along with cancer cells, it can attack some of the other healthy cells in the body also, which are fast growing. Typically, that's what it does. That's why more common side effects are hair loss, nausea, diarrhea, because the cells lining your mouth, cells lining the intestines, hair follicle cells, these are all fast growing cells. Blood counts go down from chemotherapy because, again, bone marrow cells where blood counts are made are also being affected directly by chemo, just as how it affects the cancer cells, it can also affect some of the healthy cells. That's why you end up having those side effects. Immunotherapy, on the other hand, is more to do with your own immune system, that it's revving it up, and that's why I would say the side effects are also not as drastic as chemo. Just wanted to present some of the names here because these are probably the terms that you come across in media. When I give a talk, we're not supposed to put brand names. I just took the liberty of doing that. I'm just disclosing only because of familiarity, you might be able to associate things better. So right now, these are the immunotherapy drugs that are commonly used in lung cancer. Pembrolizumab. The brand name is always advertised by the drug companies. Atezolizumab, ipilimumab, nivolumab, durvalumab. These are, anytime you see the word or the last letters MAB, M-A-B, that is immunotherapy. That's a brief, easy way of remembering that with all those names that come across. This is one trick which my teacher taught me when I was in training. So when these drugs were just coming out back then. So anything with a MAB is usually immunotherapy. And then targeted therapy, the other one with pills. I just wanted to list this also, just in case some of you are familiar with the names. Again, these slides will appear later on. These are different names. These all end with the letters NIB, NIB. That's how you can recognize that it's a pill and it's a targeted therapy. Osimertinib, erlotinib, alectinib. These are all different names here. I think the slides will be put up on YouTube afterwards in case you want to refer back to them. And these abbreviations here on the left side of the hyphen here are basically, these are mutations or markers that we use to decide which medicine would be appropriate when we talk about personalized medicine, these are all things that we look at. I'll talk about that in more detail down the road, but this slide is just to give you an idea what are all these different types of treatments used to treat cancer this way. Once again, I want to bring your attention to the staging slide because my next few slides, I'm going to talk about treatment stage-wise, very briefly. I'm not getting into any details. That's why I wanted to coin this talk as lung cancer, the basics, because just to give you some concepts as to how we treat, to give you the rationale of why we use those treatments. So stage 1, just the lung, stage 2 and 3, lymph nodes, stage 4, elsewhere. So how do we treat these different stages? I will talk first about non-small cell because it's more common. Only my last couple of slides are about small cell. So in general, we say stages 1, 2, and 3 are considered curable. Stage 4 is the one which is, it's treatable. We have treatments. All these different treatments I talked about are used to treat all different stages. But the basic difference between stage 4 and other stages is stage 4 is treatable, but it's not curable, meaning we can't take it away completely ever because the cancer is already spread and gone to other parts of the body. 1, 2, and 3 is different because it's still confined to that area of the body. So it is treatable and curable. So when we say curable, treatable, what it means is there's always a finite endpoint of treatment for these early stages. Be it surgery, radiation, chemo, different modalities. You use a treatment either for 3 months or 1 year or whatever, longer, but you know that there's a stopgap for that. When we say treatment in stage 4, it's indefinite. It's an ongoing treatment here. I always tell my patients, the analogy is similar to certain medical conditions like diabetes or high blood pressure. Diabetes is a condition that's not curable in this day and age yet. It's treatable, meaning we can give you medicines, we can do treatments to control the sugars, keep them under check. We can never just take it away completely because you have to stay on those diabetes treatments, be it the pills or the insulin injections. You have to stay on them long term. So treatment of a stage 4 metastatic condition is similar analogy. We can maintain the disease, you can shrink the tumors and control it, but you have to stay on treatment long term. The goal of treatment here is to prolong life, give more quantity by controlling the disease, but also quality. We also want to maintain quality. The side effects from the treatments we offer, we want to pay attention to that. If it's too much, we want to back off. So we want to strike that fine balance of quantity and quality here. Whereas the earlier stages, 1, 2, and 3, our goal is cure. So we do the treatment, you're done with the treatment, and then we hope that the cancer never comes back again. So what types of treatments do we use for each of these situations? For stages 1, 2, and 3, all these modalities are used in one way or the other. In certain cases, only surgery. Certain cases, surgery is followed by radiation. Sometimes it's followed by chemotherapy. Rarely, immunotherapy and targeted therapy also are playing a role. We have some new data, new studies that have come out in the last few years where we are starting to use these other things also in early stages. Stage 4, typically surgery does not play a role because, again, it's the basics, what I talked to you a few slides ago. Surgery is only going to treat whatever you're going to remove, pluck it out and remove it. If the cancer is already out in the body circulating, how much are you going to be cutting out or how much are you going to be doing surgery on? That's why it usually doesn't play a role here. Same thing with radiation. It's only those powerful X-rays, whichever part of the tumor you're using to treat, it's going to shrink that or treat that. But once it's out in the body, it's circulating around, you're not really going to radiate the whole body. We don't do that for lung cancer. So mainstay of treatment for stage 4 is the systemic ones, which is those that go throughout the body, throughout the system. So it's a chemotherapy or immunotherapy and your targeted therapy. Those will be the mainstay of treatment there. Whereas for other stages, all these are used in a different type of modality there. I really like this slide because I think it's pretty much summarizes everything I want to tell somebody about my patients about the types of treatments and stages. The earlier the stage of cancer, higher are the chances of cure. So stage 1, very curable. Surgery is offers the best chance of cure. So we always send the patient to our lung surgeon, who will then do surgery. Sometimes patients are older, they may not be able to handle surgery. Then we offer radiation. We send them to the radiation oncologist, who will do that pinpoint focus radiation just to the tumor, called stereotactic body, SBRT. Stage 2, remember, this is the one where it goes to the lymph nodes. Again, we do surgery because it's still early stage. Surgery offers best chance of cure, so you remove it. Invariably, when it's stage 2 and moves to the lymph nodes, we always follow it with chemotherapy, because again, the medicine goes through the body, into the blood, throughout, because the fact that it went to the lymph nodes means it could escape and go throughout the body. So you want to get a handle of that. You want to get a hold of that. So that's why we do chemotherapy always after surgery. In this day and age, there is some data. We could use pills, targeted therapy, could use immunotherapy, but the tumors need to have certain features. We test for that. And in appropriate cases, we do it. This is what's called as personalized medicine. When you hear and read articles about it in the news and media, they talk about the era of personalized medicine. This is exactly what it is, because what's applicable to one person may not be applicable to another because of their tumor features. We check the cancer cells for these features and then decide which one is appropriate for that particular patient. Stage 3 is very tricky because there are so many different ways of treating. Usually use multimodality treatment, we call it, meaning different types of treatments. Most common preferred type. Remember, stage 3 is where it moves to the lymph nodes in the middle of the chest, higher lymph nodes by the breathing tube, by the trachea. Usually it's chemotherapy, radiation together, and then it's followed by immunotherapy. Sometimes we use chemotherapy and immunotherapy and then follow it with surgery. So there's different ways of doing. This is one where we discuss with our team of colleagues, surgical colleagues, radiation colleagues, medical oncology colleagues. We sit at meetings called tumor boards, tumor board conferences that happen at different hospitals. We present a case, we talk, we look at the images, the pictures of the scans, pictures of the biopsies, and each specialist gives their input about which one would be best. We brainstorm and powwow, trying to decide what would be the best way to treat that particular situation. So this is one where we talk more about that. Stage 4, as I said, common way of treating that is not surgery, not radiation, but these types that go throughout the body, the system-wide treatments, chemotherapy, immunotherapy, targeted therapy. This slide probably may be a little too much, except if somebody is dealing with stage 3 cancer or has a loved one that has stage 3 cancer, then I think the slide is helpful for them. So I only put it up just with such people in mind, because stage 3, again, there's other A, B, and there's a C also now. There's a slightly older slide, so it doesn't encompass, but these are the basic rules for stage 3. Usually combined modality. Optimum regimen is actually still not clear. There's a trend towards incorporating everything: surgery, radiation, chemo, immuno, all of those. Generally, yeah, they say no surgery, but again, if the lymph node disease in the lymph nodes is minimal and less, then we still try to get them to surgeons to have surgery done. Again, there's no single treatment regimen for all patients. It's not like one size fits all. We have to look at each tumor type, patient type, and then decide. Ultimately, we say we have to manage individually. We discuss it at our tumor board conferences. This is a more common. Stage 3 and stage 4 are actually, or traditionally, these are the stages where lung cancer usually gets detected or picked up. But nowadays, we're picking up more and more stages 1 and 2 because of that CT lung screening initiative I talked to you about. If you have somebody who is deemed to be at high risk for lung cancer, we are recommending CT scans on a yearly basis, only because we can pick them up at an early stage, like stage 1 situation or stage 2 situation, which curability or cure rates are much higher than in the other stages. So that's why we talk about this. Stage 4, I just put up this slide. I was debating whether to delete it or leave it on. I just thought this is all done behind the scenes, but I think it'll just give you a little peek into what happens when we make those recommendations about treatment. We check what is known as mutations and markers on the biopsy tissue and tumor tissue, and sometimes even on blood, because what we are checking for, it's called an NGS panel, next generation sequencing panel it's called. These are basically genetic changes molecular changes and markers that we see on the cancer cells. That'll help us then decide and dictate, and it's like a tailor-made treatment then for that particular individual, individualize the treatment. These names are different commercially available labs which run these tests. Tempus is one such test. Foundation Medicine is another one. Guardant is a test that's done on blood. So if you hear your doctor saying or using these terms, just know that this is what it refers to. PD-L1 is a marker for immunotherapy. You know, all those medicines about immunotherapy that I talked to you about, the mechanism of action. In that little cartoon I showed with that orange triangle, which is the immunotherapy medicine, what it gets attached to is that PD-L1, it's called. Only if the cancer cell has this marker could we use it in some situations. In some other situations, we don't check the marker. And these in the parentheses here, those all those abbreviations and alphabets that you saw earlier are types of mutations or genetic changes that we look at in the report. So if a person's lung cancer cell has this particular marker or mutation, then there is one type of targeted therapy or pill they become eligible for. If they have this marker, then it's a different pill. So also all of these markers have different FDA approved pills that are commercially available. And there are many, many more that are being studied in clinical trials. I hope this projects okay. This is a nice little chart which summarizes just the stage 4 treatment pathway. Kind of this was a segue to the other one. When you check these markers, the way it helps us decide what treatment is right for a patient with stage 4 is you diagnose somebody with stage 4 non-small cell lung cancer. We check mutations, we check that PD-L1 status. If the mutations are present, then depending on which genetic marker or mutation the person has, we can give that appropriate treatment. Remember that slide I showed you with all the pills? I'll show it again. So that's how we match up which pill to which marker. Now, a person usually doesn't have more than one. It's only one of these markers that is present. If these markers are absent, but this PD-L1, that immunotherapy marker, is present, then we could do just immunotherapy alone, which is so much better handled and tolerated than chemotherapy. If markers and mutations are all absent, then we go to the good old standard, which is chemotherapy. It used to be only chemotherapy, but in this day and age, we're doing chemo with immunotherapy. So it's a combination. This is the one I was talking about. So when you have these different markers matching up the targeted, these are those pills. I showed this in one of the earlier slides also, depending on which marker. In terms of chemotherapy, I just thought I'll put this slide just to familiarize yourself with the names of the medicines. There's always the first line regimen. This is a platinum-based doublet regimen. Always chemo is given as combination sets of 2. One is a platinum drug like carboplatin, and then the doublet here can be, it's like a dealer's choice. It's any of these 2 that we can pick and choose depending on the side effect profile. I'm not going to go into details because, again, my goal is just to give an overview. If a person, the cancer progresses and grows on this, then move on to another second line regimen. Remember, I said for stage 4, you have to stay on treatment long term. So if the disease grows through one treatment, we move on to the next treatment. Taxotere ramucirumab. Some of you may be familiar with this. This is a standard second line we use for non-small cell. Or clinical trial is always encouraged because that's how new drugs get FDA approval, only when you study it in the form of a trial. And if cancer grows through that, then there are other drugs that I listed here, gemcitabine, vinorelbine, that can be used also as options. Or if there is an appropriate clinical trial, talk to your doctor. If that is an appropriate thing better than the others, then you can always enroll in the trial. We always highly encourage patients to do that. And again, a clinical trial discussion will be a whole different subset. Patients are worried about it. There are some trials which are very well designed where you're not a guinea pig. So those type of trials are very safe to be a part of. And even if cancer grows while you're on the trials, you can always try the standard of care treatment afterwards. Just last couple of slides, few slides about small cell cancer. Staging is very similar, confined to the organ. spreading to the lymph nodes or spread out. Again, treatment, again, same concept, same principles. Early stage, stages 1, 2, and 3 are curable. In small cell, the terminology we use is called limited stage. For all of these 3 stages, we club it together. And if you remember what I said early on, we usually don't resort to surgery here. It's chemotherapy, radiation. Unlike the other one, non-small cell, where it's stage 1, stage 2, we try to do surgery. So for small cell, if it's early stages, the standard treatment here is concurrent chemotherapy and radiation. So we do chemo and we do radiation, and followed by, this is one unique aspect of small cell cancers, radiation is done to the brain, even if there's no cancer there, just preventatively. Preventatively, it's done because this type of lung cancer has a high chance of spreading to the brain. Again, in this day and age, I think radiation oncologists are moving away from this a little bit. It also depends if the person is older. If they feel the side effects are too much, then they may not offer it. So we're not seeing it offered in everyone. If it's a young patient, I think they're more inclined towards offering it. But in general, this is how the pathway is. And these are just names of some of the chemo drugs we use for small cell. I thought I would put it out there just to so that you can get yourself familiarized if you're interested. Platinum-based doublet again. So cisplatin, carboplatin. The standard partner drug here is called etoposide. If a person has kidney problems, sorry, I should have put this in common English, renal insufficiencies, kidney problems, or if they're older or hearing issues, then we don't like to use cisplatin. We use the other drug, carboplatin. Again, stage 4, which is not curable, it's called extensive stage, this terminology just for small cell. Here, we don't really check those mutations and markers. This PD-L1, the immunotherapy marker and mutations are not used for small cell. That's all for non-small cell. Small cell, the mainstay still is the standard traditional chemo. We are using immunotherapy, but we don't check markers for that. We just use it. If it's stage 4, then immunotherapy is used. For other stages, for small cell, we are not using immunotherapy at this point. That could change a few years down the road. If I'm doing the talk again, then it might be different data. For frontline, first line at new diagnosis, we do chemotherapy and immunotherapy. These are some of the names of the medicines. After this, we do maintenance with just immunotherapy, and these patients only get immunotherapy without chemotherapy, so their quality of life is much better. Side effects are much milder, and we keep them on that way. If cancer grows on this, then we have second line treatments, other chemotherapy medicines like lurbinectedin, topotecan, irinotecan, or as I said, clinical trial, because we always prefer this. If there is a good trial that the patient is eligible for, available in the geographic area, then we're always, as oncologists, we're always looking to consider or offer that to our patients. So if your doctor is talking about it, definitely please give it some consideration, because that's how these new medicines come into existence. This is a way of getting the benefit of the newer drugs before they become FDA approved. I think that ends my talk.